Welcome everybody, and as was mentioned, this evening is really about diabetes prevention. I don't have any, whoops, it's not working. There we go. I have no conflicts of interest or financial disclosures with respect to the series, and what we're going to cover over the next 10 minutes or so is to look at some of the evidence base with respect to implementation of various modalities of diabetes prevention. So they're going to be a range of things which we'll cover. We will also then look at how this may be translated in primary care, look at preventing or perhaps delaying the onset of type 2 diabetes in general practice, and finally, we will have a list of resources, which I won't go through in any detail, but you will have access to these, but I will just very briefly, I guess, showcase some of these that are available to you. So what I'd like to do is to transport you back a couple of decades to a publication, a landmark publication, an epidemiological publication in Melbourne, from the Baker IDI, as it was known at the time. And it was essentially using postbox, postal code, I beg your pardon, to essentially screen adults over the age of 25 for a range of things. And among those things was the prevalence of diabetes, obesity, and a number of other things. And what they found was that just about 7.5% had diabetes, which equated to doubling over the past 2 decades. But an additional 16% of the population, and remember, these are over 25, we're not talking about over 50, over 65, had pre-diabetes defined as impaired fasting glycemia or impaired glucose tolerance. And around that time, about 60% were overweight or obese, and we know that that has, of course, progressed since then. So 1 in 4 had some form of dysglycemia. Now those individuals were revisited at a later stage, 5 years down the track, and they wanted to see what the progression to diabetes was. And those with normal glucose tolerance, there was about a 0.2% per annum conversion to diabetes. However, if you had pre-diabetes, either impaired fasting glucose or impaired glucose tolerance, the risk was around 10 to 20-fold higher. And so clearly it makes sense that this is going to be your money shot. This is where you're going to get the best bang for your buck if you target these high-risk individuals. And remember, it's not a small number. You know, we're talking about 16% of the population over the age of 25. So, sorry, I'm not sure if this is included, but anyway, it's as I mentioned, it's a 10 to 20-fold higher risk. Now, there were a number of studies that have been conducted over time. These are some of the most widely and repeatedly quoted, and I've just presented these as a selection because they really give a global representation. So these are different ethnicities, different methodologies, wealthy countries, developing countries, and we see actually fairly similar outcomes. So what we see here is that lifestyle programs, so these were lifestyle interventions, and they had certain similarities, calorie restriction, increased physical activity, and not a bad result. At the end of the study, you had a 40 to 60% relative risk reduction in new onset diabetes. And if we convert that into, you know, bang for your buck, or whether this is a worthwhile intervention, numbers needed to treat, you know, were 20 to 30. So once again, fairly worthwhile interventions. And I just want to share a little bit of data with you from one of the biggest studies, which is the Diabetes Prevention Program. That's the one at the bottom there, with over 3,000 individuals. And that is, we see here that, in fact, lifestyle modification, which was in the green, versus metformin in the yellow, actually lifestyle modification outperforms pharmacotherapy. And not only that, the oldest cohort actually did best. So it's never too late to intervene. And again, if you have a look at the box on the right, you can see that the goal and the methodology is really quite modest, real world. We were looking at a 7% reduction in body weight, so calorie reduction, and around 150 or more minutes per week of moderate intensity exercise. This is what we recommend in the real world. So this is not, you know, biggest loser intensive crazy stuff. This is stuff that is achievable and doable in our own practices. But sometimes we need to ramp it up, we need to intensify, and that may mean introducing pharmacotherapy. So once again here, a smattering of studies using pharmacotherapy, and just to show you those that involved diabetes medications. So why are we not moving? So those that involve diabetes medications, you would expect, at least intuitively, you would think that those medications would reduce new onset diabetes because of their mode of action. And you see here the diabetes prevention program, 30% reduction. Remember, lifestyle was 50% reduction. And we see at the bottom, liraglutide used as a weight loss agent in people with prediabetes, very effective with a 50% relative risk reduction in new onset of diabetes. But what about if we look at agents that don't have any effect on glycemia? So we have orlistat, we have phentermine topiramate, combination available elsewhere, not in Australia, but nonetheless, what we're looking at is purely the impact of weight loss, because these have no effect on glycemia per se. So any benefit that might be accrued from these is purely related to the weight loss that they've achieved. So if we look at the benefit, if we try and quantify the benefit of weight loss, again, the news is pretty good, because the best bang for your buck, the maximum benefit you're going to get in preventing new onset diabetes is in the 5 to 10% weight loss, which is really quite similar to the 7% weight loss goal in the diabetes prevention program. Once again, it is within reach of many of our patients and certainly doable within a primary care setting. And if we want to further quantify it, there's this a meta-analysis looking at the relationship between weight loss and HbA1c reduction. So these were individuals with diabetes, but the principle applies throughout the continuum of dysglycemia. So 58 articles and 17,000 subjects. And what they found was that an HbA1c reduction of 0.1% was generally associated with 1 kilogram of reduced body weight. So if somebody loses 10 kilograms, that equates to around 1% HbA1c, pretty well just as good as most of our pharmacotherapy. And of course, there are so many other benefits to that 10 kilogram, or, you know, it might be 10, 11, 12% body weight loss. So a very, very worthwhile intervention. So what should we be doing in primary care to prevent type 2 diabetes? Well, the buck stops with us. No one else is going to do that. So we need to identify those at highest risk. And again, just to summarize the entire textbook of medicine, genes load the gun, environment pulls the trigger, and age determines the outcome. All the rest is small print and commentary. So what are the genes? Well, it's going to be not only immediate family history, it's also going to be race and ethnicity. We live in an obesogenic environment, and that environment is going to impact weight and type 2 diabetes risk all the way from the intrauterine environment all the way through the full trajectory of life. And so we're going to be looking at those individuals who have become overweight or obese because of these obesogenic impacts of the environment in which we find ourselves. and particularly central obesity, which as we know is really what we are concerned about when it comes to health issues. Other features of insulin resistance, metabolic syndrome, polycystic ovarian syndrome, prior history of gestational diabetes, and so on. And remember, a group that's particularly vulnerable is anyone on antipsychotic medication. Not only is the medication diabetogenic, but these individuals are already at risk by virtue of their underlying condition. If we look at age, anyone over the age of 55 as increasing age is the most potent risk factor for diabetes development. Anyone over 45 with at least one other risk factor, and of course, Indigenous Australians are, as you know, at particularly high risk of not only diabetes and its ravages, but they really do struggle and suffer with adverse health outcomes in many domains. So what do we want to do? What do we aim to achieve? Well, we want to maintain a healthy weight or achieve a healthy weight or as close to as we can possibly get. And as we mentioned, 5 to 10% body weight loss is that Goldilocks zone, that sweet spot. Regular physical activity, again, 150 minutes a week, more is better. And what kind of exercise? It's really the exercise you're going to do. That's the one that counts. Every bit of physical activity, vacuuming, gardening, walking, running, it's all great stuff. And eat the right types of food and not too much. Again, no magic sauce here, no secrets that I'm revealing. Everybody knows this. Managing, of course, the other risk factors of cardiovascular disease. So these are really the attendant features of metabolic syndrome. We want to, of course, manage lipids, and smoking, of course, is an absolute no-no. So how do we fund this? We're all in businesses, we're all in busy practices. You've got your care plans, your team care arrangements, and of course, anybody with diabetes and with significant risk of diabetes would qualify. You've got a number of health assessments, your 40 to 49-year-old check, your 45 to 49 diabetes checks, and so on. And you would know all about these. You certainly don't, I'm not going to try and teach you to suck eggs here. You've got practice nurse item numbers that at least will help fund some of the input of chronic disease nurses who do an outstanding job in supporting us and facilitating some of the things that we try to do when we are time poor. So you can share the love beyond your practice, of course. You may have a dietitian that's co-located with you, but certainly if you don't, you may have a network of people that you may refer to, and a credentialed diabetes educator, particularly who understands the space of diabetes and dysglycemia, is that they're worth their weight in gold. Exercise physiologist, again, takes a bit of explaining to patients that this is not a personal trainer. You don't need your leotard. They will work out an exercise program that's very specific to the pathology we're addressing. Diabetes educators, again, as their name suggests, they are wonderful in providing education, improving health literacy of our patients, who will hopefully then move on to adopt many of the healthy life habits that will serve them in good stead, not just in terms of diabetes prevention, but a whole range of other things. So we do have organizations, of course, that will provide some support, and within those organizations, there may be a range of programs. There may be new programs. There may be programs that get cold because of end of funding. So really, in the time allotted, we can't go into much detail. Community health centers will often have programs, and of course, government and PHNs may also jump into the mix. So you can prescribe and you can refer. So remember, as we move along, if we need to intensify, it may involve prescribing. You may prescribe metformin because there is evidence to support that. I showed you one study, but there are many more. But remember, this is off-label. We do use it for polycystic ovarian syndrome. This is also off-label. And you would need to have that conversation with the patient. You would need to do this as a private prescription. And of course, weight loss medications, as I showed you, can be very effective in reducing insulin resistance, reducing dysglycemia, and hopefully having individuals moving from prediabetes to normoglycemia. And in particular situations, metabolic surgery may be appropriate. These are, of course, specific circumstances. This is not for everybody, but once again, this is probably the most intensive end of the spectrum. If you've got somebody at particularly high risk, this may be something you might contemplate. I mentioned also that we have lots and lots of resources. I'm just going to flick through these very quickly, but they will be made available to you, so you'll have the ability to access them at your leisure. So we have podcasts that are available to you. You might listen to them walking to work or driving to work. You've got a range of publications that are available to you. Of course, the offerings go way beyond some of these that we are presenting and offering here. Don't forget, we do have guidelines. We have our type 2 guidelines, which are specific for general practice, our type 2 guidelines. And remember that diabetes is a cardiometabolic syndrome. So you also want to be looking at cardiovascular protection. We're not just being glucocentric. Again, you will probably have your favorite guidelines that you will go to and access.